क्योंकि आप लोग मुझे पढ़ाओगे, मैं नहीं पढ़ाऊंगा। अरे भाई, क्या पढ़ाने के लिए स्लाइड देखना जरूरी है ना? अरे भाई, first of all, it is always an honor for me to be here in Vedanta, and I prefer to use, this is a review course, so we'll be more discussing about cases rather than going to the theories. What do you think? I have only 25 minutes time for each talk. I'll be talking one after another. So we'll be discussing cases. So let's see the ध्यान से देखो. So it's a 48-year-old male, hypertensive and smoker, presented to the emergency department with retrosternal heaviness for past 30 minutes, which is not relieved by rest. Okay? And he also has shortness of breath. He's diaphoretic. His vitals are heart rate 74, blood pressure of 164 by 90. His SpO2 is 96% on room air. Otherwise, systemic examination is normal. TROP-T report is awaited, but ECG is done. Can you see the ECG? That's the reason I asked you to come forward. Can you see the ECG? So what is your opinion about this ECG? Normal? Okay, let's come to the questions. So tell me, which one of the following statements is the most appropriate in the management of this patient? So if first one, normal value of highly sensitive troponin T will rule out acute MI in this patient. Do you agree? Who says yes? So it is a uniform answer, no? Alright, so you want to repeat it, okay? So your suspicion of acute coronary syndrome in this patient is extremely high. So second question is bedside echocardiography done now. It can rule out a myocardial infarction in this patient, yes or no? Great. So aspirin should be chewed immediately in a dose of 150 to 300 if you are in Europe, and 160 to 325 if you are in US, but I don't know about India. So we usually get 320 milligram tablet. So who are in favor of this? Aspirin? All of you? So see, you are teaching me. Who wants to go for a CT coronary angiogram if the highly sensitive troponin T is negative? Anybody? Yes? So actually there is no role of CT angio is to be done for non-high risk patients. Okay? Supplemental oxygen should be initiated. Who is in favor? When do you want to initiate supplemental oxygen? Less than? एक बोलो, बोली लगाए 94. ओके, इससे नीचे कोई 90 के लिए तैयार है? 90. This girl is bold. She wants 90. Okay, good. So let's see what is ACS. We all know it. ACS is a clinical syndrome, results from the decreased blood flow to the cardiac muscles. Usually it is produced by the plaque rupture or plaque erosion, leading to coronary artery thrombus. But there are some cases of acute myocardial infarction which can be because of demand supply mismatch. We'll come to that. So myocardial infarction is diagnosed. The single most important point is that you have to have an evidence of myocardial necrosis in the form of elevated cardiac enzymes. Now we have highly sensitive troponin T, so that has actually increased the number of myocardial infarctions. Apart from this, you need to have at least one of the four: the classical history, new onset ischemic ECG changes. If the ECG changes shows ST elevation, then you separate it into ST elevation myocardial infarction, which has got a different type of treatment protocol. If it is not so, but there are some STT changes, then you call it non-ST elevation myocardial infarction. New evidence of RWMA, regional wall motion abnormality, and a thrombus detected in the angiography or after death in autopsy. And when your myocardial necrosis is not there, but patient has classical symptoms of acute coronary syndrome like this guy had, or you have some T or STT changes, then you call it unstable angina. So these patients will classically will not have a cardiac enzyme elevated. Now there are different types of MI. You as an examiner, I would like you to know this. There are type 1 to type 5 MI. There in ICU you get type 2 MI most commonly. So if you do randomly without thinking about anything, just do the tropi. Oh, tropti kara dete, tropi kara dete, and you will find in 70% of the ICU patients, the real ICU patients. I don't mean ICU patients who are reading newspapers. The real ICU patients, you will find in 70% of them TROP-I or TROP-2 will be positive because of the demand-supply mismatch. So this is the type 2 myocardial infarction. So you need to read it because I may ask you. If unfortunately I am your examiner, okay? And these are the two big studies which have shown that oxygen supplementation, unless it is less than 90%, there is no role of it. In fact, if you give oxygen to patients who have a SpO2 of over 94%, you can actually increase the infarct size, you can actually increase the incidence of recurrent MI, and you can increase the incidence of arrhythmias. So oxygen to be supplemented, maybe if it is more than 90%, but I am not that bold, I will suggest more than 92%. Okay? Now let's come to the second case. आप जब भी बोलोगे मैं बंद कर दूंगा. Okay? So we'll come to the cases. So let's see this gentleman, 76-year-old male, hypertensive diabetic, who had a history of ischemic stroke for which he was thrombolized a year ago. Now he is better. He can move without support, without any support, and he can do his household core work. Now this guy, this elderly gentleman, he presented to us with a chest pain of 1 hour duration, retrosternal heaviness, chest pain. On examination, he had got a heart rate of 46, blood pressure of 104/50, SpO2 of 92% on room air. He is diaphoretic, extremities are cold, and lungs showed bivasal crepitations. And can you see the ECG, all of you? So tell me your interpretation. Tell me the findings. What do you see? है बेटा एक जन ध्यान से देखो. Any other opinion? Somebody said ST depression. Where is the ST depression? So how do you see a bundle branch block? How do you see a left bundle branch block? White QRS with ST going opposite direction, ST depression or ST elevation is going opposite direction along with the T. If it is ST is the QRS upright in the V5, V6, we call it left bundle branch block. If the QRS is upright in the V1, V2, then we call it right bundle branch block. Am I right? So can you again comprehend? So is it? So this is an LBBB, left bundle branch block. So we have an elderly gentleman with left bundle branch block and who is in distress. He is in acute heart failure. Do you agree with me? Okay. Now you see this area. So normally, if you see the ST depression is in the downward side, what you call discordant. QRS is upright, ST is going down. So this is the normal pattern. But here you can see this is concordant. The ST elevation is along with in the same direction as the R wave. So keep it in mind. So this is important. How do you diagnose myocardial infarction in a patient of left bundle branch block? This is important. Garbosa criteria, very good. So before that, I'll ask some questions. So what is the most important initial step in the management of this patient? Most important. It can be two also. Cath lab should be immediately activated. Who is in favor of this? And why do you think so? So there is a possibility from the ECG that it can be an ST elevation myocardial infarction, and most importantly, patient is hemodynamically unstable because of heart failure, not because of blood pressure. Patient should be loaded with clopidogrel in addition to aspirin. थोड़ा आगे बढ़ते हैं, है ना. थर्ड क्वेश्चन, थर्ड ऑप्शन, ticagrelor is preferred over clopidogrel and should be administered in addition to aspirin. So who wants to give clopidogrel and who wants to give ticagrelor? Ticagrelor. Now who wants to give prasugrel? Who is in favor of prasugrel? So what are these drugs? These are called P2Y12 inhibitors or ADP receptor antagonists. So these are the antiplatelet agents. There are three types of antiplatelet agents we use: aspirin, P2Y12 inhibitor and GP2B3 inhibitors. And for us intensivists, I want you to know that you have to know where to use what. GP2B3 है, हमारा नहीं है, cardiologist use करते हैं. But P2Y12 inhibitor, you should need to know it. So we'll come to that. So who is in favor of 3? You are in favor of 3. Who is in favor of 4? 3 or 1? 1 सबके लिए है. Okay. So 1 और 3, most likely 1 and 3. So we'll come to that. So these are the criteria. You all know ST elevation MI, we can be diagnosed by an ST segment elevation by more than 1 millimeter in all from the J point in the contiguous lead, except in lead V2 and V3. In V2 and V3, the cutoff is depends on the age of the patient and the gender of the patient. If it is a male more than 40 years, is more than 2 millimeter. Female of any age more than 1.5 millimeter. Male of less than 40 years, it should be more than 2.5 millimeter. In a young male, you get something called early repolarization, where you can get a elevated ST segment. So for a young male, you need to have, young male by me, I mean young males means less than 40 years, not people like me. So less than 40 years is 2.5 millimeter. But if there is a LBBB, this lady from Spain, Garbosa, she described a criteria in NEJM back in 1996. So this is called the famous Garbosa criteria, but the sensitivity and specificity of this criteria is not very high. It is around 65% sensitivity and around 70% specificity. No, specificity is high. Its specificity is close to 90% plus, but sensitivity is only 65%. So as I told, the concordant ST segment elevation, as can be seen from this diagram, the same way ST segment is going up, the same as the QRS complex. Concordant ST segment depression of more than 1 millimeter and discordant ST segment elevation by more than 5 millimeter, and they have been given 3 different points, and based on these points, if the points are more than 3, then we call Garbosa positive. But as per the latest guideline and as per the new recommendation, we have to follow this algorithm, and I want to remember by heart. First of all, if you have a patient with the evidence of or the clinical suspicion of acute myocardial infarction, first you see whether your patient is hemodynamically stable or if the patient has got acute heart failure. If there is evidence of hemodynamic instability or acute heart failure, take the patient immediately to the cath lab. So the option number 1 is absolutely correct. This young lady is correct. If the patient is hemodynamically stable or there is no evidence of acute heart failure, you go for the Garbosa criteria. If the Garbosa criteria says yes, then again ST segment elevation and you take the patient to the cath lab. This patient fulfills the Garbosa criteria also. You remember, there was a concordant ST segment elevation by more than 1 millimeter in AVL. If Garbosa criteria is negative, then you go for echocardiography and TROPS and other things and you decide accordingly. Okay, but these two first things, hemodynamically unstable and Garbosa criteria, must be remembered. Regarding indications for PT-Y12 inhibitor, whenever there is a suspicion of ST segment elevation MI, it has to be started immediately. So you start, there is something called dual antiplatelet therapy. Okay, so you start an aspirin, shuru mein, as soon as you have a suspicion, you give aspirin and you start, if there is an ST segment elevation, you start the second antiplatelet agent. If it is an NST-MI, non-ST elevation MI, please do not start the, at least theoretically for your exam, because practically is different. You don't start it before you actually see the coronary anatomy. Kyun? Why? Because some of the patients may turn out to be a triple vessel disease after coronary artery, or may turn out to be a difficult left main block. In that case, this patient may have to be taken for a coronary artery bypass grafting, where the bleeding incidence will increase significantly if you give dual antiplatelet therapy. Or maybe some patients may have a differential diagnosis like dissection of aorta, where a dual antiplatelet therapy is contraindicated. So if you have an ST elevation MI, start dual antiplatelet therapy. Non-ST elevation MI, wait for the cath lab. If you see the coronary anatomy, then start the second things. Now which one? There are 4 actually: clopidogrel, prasugrel, canagrel and ticagrelor. Out of these, few things are very, very important. There are randomized control trials which have shown that prasugrel and ticagrelor are better than clopidogrel. But we need to remember, clopidogrel and prasugrel, they are not active drugs, they are metabolized, whereas ticagrelor is not metabolized. They can be given, they are active drugs. Prasugrel is contraindicated in patients with prior history of stroke. So, कौन देना चाह रहा था prasugrel? कोई नहीं ना? So you knew it? Yeah, prasugrel is contraindicated. So this gentleman, this elderly gentleman, had a history of stroke, so we can't give prasugrel. Do you agree with me? So we can give ticagrelor. Ticagrelor is preferred. What about ticagrelor? We all know the dose, and doses are all available in the smartphone, so we don't need to remember these doses. You can take it from the smartphone. But again, ticagrelor is shown to be better compared to clopidogrel. But there is a head-to-head comparison between prasugrel and ticagrelor. One randomized control trial has shown that prasugrel is actually better than ticagrelor. So if you have no contraindication, prasugrel is preferred over ticagrelor, at least by the study result. But if there is a contraindication, ticagrelor is preferred. Clopidogrel, if both the things are either not available or both are more costly, and if you are not planning any PCI, then you go for a clopidogrel. Okay? Okay? Clear? And what about GP2B3A? This is actually the cardiologist's job, but for our information, in case of during angioplasty or during the procedures, if the patient develop no reperfusion, then you go for a GP2B3A drugs. There are 3 drugs available: F6imab, eptifibatide and tirofiban. Epciximab is no longer, it is going out of favor, but rest of the 2 are there. But this is only for the patients where reperfusion is not being achieved. What is something called TME3 flow is not achieved. Or patient develops a recurrent symptoms. Or patient develops a type 4 myocardial infarction post angioplasty. So in those cases, so this is actually not an intensivist job. थक तो नहीं गए? Let's go for case scenario 3. So 60-year-old female, BD smoker, not very uncommon in Haryana. Okay, diabetic, presented to the emergency department of a district hospital, maybe आप सोच लो, maybe new in Haryana, where with a history of crushing pain in the center of the chest for 45 minutes, heart rate 74 per minute, blood pressure is 94/50, systemic examination is normal, and the nearest cardiac cath lab is 4.5 hours away. ECG देख लो, कुछ कमेंट? आपके लिए मैं गोला भी बना के रखा. Can you just in your mind, can you just rotate this film and see it from the back? But what are you suspecting? Posterior lamina. Why are you suspecting? So if you can see, there is a ST depression in the anterior leads, and there is some R wave in the V1 and V2. So if you can just rotate it, you can see this like a, and you can confirm it with a posterior leads V7 to V9. By the way, V5 कहाँ पे लगाते electrode? Which intercostal space? Which line? Anterior axillary line. Paka. V5. And V6? And where is the anterior axillary line? Which muscle? Which muscle? Pectoralis major. And what about V7? Latissimus dorsi. All right. Now let's come to the question. What is the best initial step in the management of this patient? Subcutaneous enoxaparin you want to give? Yes. Because this is probably a posterior MI pending the other report. Transport the patient to the nearest cardiac center for percutaneous intervention. Would you like to do that? Yes. बेटा पीछे जाओ. कहाँ गया? ओह, 4.5 घंटा दूर. You will be doing a. Okay. So you want to send the patient for cath lab. 4.5 hours. 4.5 घंटा दूर. New to GB Pant. Okay. All of you agree with her? You would like to send the cath lab? No, you don't want. They don't agree with you, it seems. You want to give intravenous fluid to this patient, but blood pressure is 94/42. Okay, she's in favor of intravenous fluid. Okay. Initiate fibrinolytic therapy. Who is in favor of initiating fibrinolytic therapy? Yes. So let's see what is posterior MI. So you all know it. Posterior MI can be is 15 to 20% of the acute MI. Usually it is associated with the inferior and lateral wall MI. So which artery supplies the inferior wall? Which artery supplies the lateral wall? So can you tell me which artery is likely to supply the posterior wall? RCA. In around 70% of the patients is the right coronary artery, where you call it right dominant artery. So posterior descending artery is a continuation of right coronary artery in 70% of the patients. In 10% of the patient, it's a continuation of the left circumflex artery. In 20%, remaining 20% is mixed. So obviously, in majority of these patients, they are all associated with inferior or lateral wall MI. Isolated posterior MI is seen in 3 to 3.3% of the patients. And these are the criteria, ECG criteria for diagnosis. You all know it, so I will not go into the details. Now let's see when do you send the patient for cath lab? If the primary PCI, percutaneous intervention, PTCA plus stenting can be done within 60 minutes. And if you are in a center, then you do it. If you are not in a center, and if you can send the patient within 120 minutes, what I mean by within 120 minutes is the wire has to be passed within 120 minutes. If it is not so, then fibrinolysis is as good as and probably better. You can always do a delayed PCI if the patient does not achieve his reperfusion or the patient remains asymptomatic. Okay, fibrinolysis is to be done if the PCI is not feasible and if there is no contraindication. Remember, fibrinolysis is not to be done in patients with non-ST elevation myocardial infarction or in patients with unstable angina. Okay. Case scenario 4, 68-year-old female, hypertensive, ED presentation with epigastric discomfort for 45 minutes, acute onset, sweating, radiating to the neck. On examination, she is in obvious distress, her heart rate is 100, BP is 112/56, she is diaphoretic. Diaphoresis is common as much as 40 to 50% of the patients. Very commonly seen, sweating patient. Lung and heart sound is normal. So any comment on this electrocardiogram? हाँ बेटा, तो पहले इसके बारे में तो बता दो, ये 2-3 AVF में जो दिख रहा है ये क्या है? इंफीरियर वाल, इंफीरियर वाल के साथ पोस्टीरियर वाल मिल सकता है और right ventricular myocardial. So you see there is an ST elevation in V1 and V2 and okay, V1 and V2. So there is a suspicion of inferior wall MI with RVMI. And how can you prove it, confirm it? Right sided leads. Okay. So let's see the question. Which of the following statement is are correct? Nitroglycerin should be started for pain relief. क्यों? So what will you give for pain relief? Morphine or fentanyl. Okay. Or can you give NSAID for pain? No? Why? Huh? I didn't get it. So it will increase the infarct size. Okay. And what about steroid? It will increase the rupture, free wall rupture, and again infarct size. What about beta blockers? Unless contraindicated, beta blocker also can reduce the total myocardial workload. So it can reduce the pain. So here you give metoprolol tartarate, not succinate. जो antihypertensive आप देते हो succinate है. Metoprolol tartarate is given 5 milligram increments of 3 doses. Can be given, but nitroglycerin should not be given. So you all agree with me? Okay. Dual antiplatelet should be started before primary PCI. You agree with me? It's an MI. And you are going for a ST elevation MI. You are going for a PCI because you are in Vedanta. आधे घंटे के अंदर आपका हो जाएगा, तो आप करोगे. IV UFH should be started before and during PCI. Yes, you can give either UFH or you can give enoxaparin, but you cannot give fondaparinux in ST elevation MI. Intravenous fluid if the patient becomes hypotensive. Who is in favor? Yes. So here you can give intravenous fluid, not in posterior MI, because RVMIs are preload dependent. So you all know this RVMI. So nitrates are also contraindicated in patients who has got hypotension and those patients who has taken phosphodiesterase 5 inhibitor like sildenafil and tadalafil and other blah blah blah. All right, last case, 76-year-old. Do I have time? Last case, 76-year-old male, heavy smoker, COAD, presented with chest discomfort for 2 hours, intermittent, or these are classical changes. He is again diaphoretic. I particularly love this diaphoresis. And heart rate of 104, BP is 84/50. So this patient has got evidence of acute left ventricular failure. He got a B profile. And for your easy understanding, I have done something. Okay. So this is the ECG. So you can see in V4, V5, V6 and V3 also there are some ST depression. So do you think this patient has got acute coronary syndrome? Yes? Do you think it's an ST elevation MI? So do you think it's a non-ST elevation MI? Maybe, but we are waiting for the cardiac enzymes. She's right, trop T or trop I, whatever you want. Alright, so it's an acute coronary syndrome. So let's see the question. Which of the following statement is most correct while managing this patient? Most correct, remember. Patient should be loaded with clopidogrel 300 milligram plus aspirin of 300 milligram. So it's ऐसे भी हम लोग clopidogrel 600 milligram देते हैं, नहीं? PCI should be planned within 2 hours if trop T is positive. PCI should be planned within 24 hours if trop T is positive. Subcutaneous enoxaparin should be initiated. PCI is not indicated in this patient. So here, if the trop T is positive, it's a non-ST elevation MI. Now let's see what are the indications for PCI in non-ST elevation MI. So we divided into high risk, moderate risk and low risk. If it is at high risk, this guy is in high risk, or this lady, I don't remember. So if there is a hemodynamic instability, patient has got life-threatening arrhythmias, patient has got acute heart failure, mechanical complication, they are high risk. You have to do the PCI within 2 hours. Alright? If the PCI is, it's not high risk, but patient has got recurrent symptoms, or patient something called gray score. I am not, there is a scoring system, there are TIMI score, gray score for risk stratification. If the risk stratification is high, then also you do it within 24 hours. Otherwise, you wait and do it at the time of discharge. Just last thing, just tell me this ECG. What do you think? This is important, this is very, very important. 58-year-old male, diabetic, old CAD, presented with some history of intermittent pain, chest pain, but now he has got no pain. Cardiac markers are sent, and ECG showed an T-wave inversion in V2, V3, and V4. So, anyone who can identify this condition, from my side, he will get 2 rupees. So beta, this is called Whelan syndrome. So as an intensivist, you should know this. This is Whelan syndrome. Okay? This is a very high risk patient. These patients are at a high risk of left anterior descending artery stenosis. Okay? Cardiac, this patient may not have pain at the time of presentation. Tropi may not be elevated, but these patients must be taken for coronary reperfusion. Okay? Because this is a left LAD stimulation. So I am done from my side. If you have any questions, I am ready. And please read this book. You will love it. Yeah. Any question?